thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinosa, the Program Coordinator at CSCLA, and I'm honored to welcome you to this week's webinar titled Advances in Breast Health, Cutting Edge Updates in Cancer Treatment and Care. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we'll get to as many as possible. And to introduce today's speaker, a Southern California native, Dr. Schulz-Costello earned her degree at Western University of Health Sciences, College of Osteopathic Medicine of the Pacific in Pomona, followed by residency at Arrowhead Regional Medical Center in Colton. But it was her comprehensive breast cancer surgery fellowship at City of Hope that sealed the deal. Dr. Schulz-Costello is especially interested in helping high-risk patients, such as those with a family history of breast cancer and the BRCA1, BRCA2, and other genetic mutations. It gives me great pleasure to welcome today's speaker, Dr. Schulz-Costello.
Awesome. Good afternoon, everyone. It is so nice to meet with all of you. I am Kat. I'm a breast surgeon at City of Hope in Duarte and Arcadia. Really, my life's passion and life's mission has been to help women with breast cancer. A huge part of treating breast cancer is education. It's education of patients. It's education of their family. And as a surgeon, it's learning stuff all the time. So much research is poured into breast cancer, and we benefit from that so much in being able to offer new technology to patients. My mom was part of a clinical trial when she had breast cancer, and honestly, it saved her life to get this medicine called Herceptin, which wasn't approved for the type of treatment that she needed at this time. So I'm really happy to share a lot of information with everybody today and also take some questions at the end. So I have nothing to disclose. I do want to give a little bit of background before we go into some newer things just about screening, genetic testing, breast imaging, talk about prevention, because these are really important topics that I think can help us, but also help our family and friends. And then we'll go into some new stuff of what's next. So breast cancer is really common. I have no doubt a lot of people on this meeting have been affected personally by breast cancer. The magic number is that it's 1 in 8 women will develop breast cancer. The chances of getting breast cancer does increase with age, and I'll show that on the next slide. And it's the most common non-skin cancer for women. The 5-year survival overall is excellent because of our ability to early detect breast cancer and also our ability to individualize and personalize medicine. So because there's so many different subtypes of breast cancer, by understanding individual cancers, weaknesses, we're able to target cancer cells that can be elsewhere in the body and eliminate them, and that results in better survival. There's lots of survivors living in the US, so survivorship is actually a big area of breast cancer. And I always like to comment, I can't see if there's any men on the call, but breast cancer can affect men. I have about 1 patient a year that is male with breast cancer. Typically, male breast cancer is found by the patient, so they usually will feel something directly behind their nipple where there is ductal tissue. And their outcomes are very similar to women too, but they're not screened like women are. So just being aware of breast self-awareness for men is important. The most common ages for breast cancer are between 50 and 69. So that represents about half of the age group for diagnosis of breast cancer. And then actually, the older you get, the higher likelihood actually of dying from a breast cancer compared mostly because of the age. It's the younger you are, it's more like rare to get breast cancer. So the way the numbers look. This is a slide just showing the presentation by race and ethnicity. So Black and Hispanic women are more likely to present with locally advanced or breast cancer that has spread than non-Hispanic women. And there are multiple layers to this. I want to share this to acknowledge this. And this is not just related to screening or, some disparities in access to care. There's also a biological element to Black and Hispanic women getting more aggressive types of breast cancer. So now that we talked about how common breast cancer is and the age groups, we'll talk about some screening guidelines. So in general, for breast cancer screening, the gold standard is mammograms, and that is an X-ray of the breast that is taken in two different ways. So squeezing the breast this way, squeezing the breast this way. And this is our gold standard. This is the least expensive test. It's the most available. It is the only test that can diagnose precancer, which often presents as calcification. So sometimes women are nervous about mammograms because you are exposed to some radiation. It's an X-ray. But it is very safe. Honestly, the amount of radiation is pretty comparable to an airline flight. So I try to reassure patients that number one, we're getting radiated every day we're on planet Earth, but it's also a very safe test, and the benefits outweigh the risks. You may have heard of 3D mammography or tomosynthesis or 3D mammogram. And this is a mammogram that actually does expose you to a little bit more radiation, but instead of taking a single picture of the breast, it actually takes some slices of the breast. This has two benefits. So one, it can actually decrease the chance of being called back. Sometimes when women get mammograms, they'll find something that looks abnormal, but they don't know what it is. So they call women back so they can take additional pictures. And when they actually squeeze the breast tissue more, they realize, oh, that was nothing. It was just like, it looked a little bit strange in this picture, but when we squeezed more, it looked okay. So 3D mammogram, because they're able to scan through the breast, decreases the chance of that happening. And the second thing 3D mammogram is helpful for is actually finding some smaller tumors and dense tissue. Dense tissue is like a very, very hot topic in the breast world. By law, all patients have to be informed that they have breast tissue dense tissue if they see it on their mammogram. And what does this mean? So our breasts are made up of milk glands, milk ducts, and fibrous tissue in between. And when we are young, our breasts are prepared for potential breastfeeding, pregnancy. And so that tissue is actually quite dense. As we get older and we lose our hormones, that dense tissue is actually replaced by fat. And this isn't as simple as that. There's genetics that influence the density of the breast tissue. There can be hormone exposure, amount of pregnancies, your age of your first period. Like there's so many things that go into account for dense tissue. And it's not necessarily something that's like, bad or there's something wrong with somebody. In a sense, dense tissue is normal. But the thing that patients need to be aware of is that dense tissue can actually hide a cancer on a mammogram, because both dense tissue and like a cancer mass both look white. And so it's kind of the radiologist saying, hey, like your mammogram is normal, but you have dense tissue. So like it may not, you could have something there. It just, I can't see it. Kind of like a disclaimer. And so what do we do then if somebody has dense tissue? So I'll get into it a little bit on the next slide, but I think every women should have a personalized kind of risk assessment. So some of that involves sometimes genetic testing when there's a high risk family history, because if somebody has a gene mutation, they'll be put into a different screening regimen depending on that mutation. But if somebody doesn't have a mutation and they just have a lot of risk factors for breast cancer, sometimes there's also kind of an enhanced high risk screening that we can offer. Ultrasound is something that is used to supplement mammography. And that can sometimes find cancers that are missed by mammogram because of the dense tissue. Every test has like pros and cons. So ultrasound is a great test. It is very operator dependent. So I tell patients, it's like if you shine a flashlight somewhere, you know, you can see what that flashlight is showing, but you can't see anything else. And so it's very dependent on the tech who is doing the ultrasound, if they see something and save a picture and show it to the radiologist. So sometimes for a screening ultrasound, if there's something bigger there, they may catch it. If there's something smaller there, they may catch it, but it is very operator dependent. There is automated whole breast ultrasound, which is a great idea. It's called the Ethnicity, where it actually takes a picture of the whole breast. However, that has limitations too, because it's limited behind the nipple, which is where some cancers can form, and it also doesn't evaluate the underarm area. So there's a lot of like pros and cons to all testing. The final breast imaging test is a breast MRI. So breast MRI is a very, very expensive test. It does involve contrast. But it can find things that both mammogram and ultrasound can miss, but it also has a high false positive rate, meaning if everybody got an MRI, we would be doing so many biopsies, and most of the biopsies actually wouldn't show cancer. So there's a harm in breast MRIs in terms of the false positives. And we use this typically for patients who are higher risk to get cancer, so those with mutations or those with a lifetime risk over 20%. In terms of just standard screening guidelines, most of them revolve around mammogram. I'm going to switch to the next slide. So the U.S. Preventative Task Force, there's all these different societies that say like when to start mammogram, when to stop mammogram, or how often to get them. And the U.S. Preventative Task Force has kind of been a stricter one, but this year they actually did change their guidelines that everybody should start getting mammograms at 40. So if there's a takeaway from this talk, it is get your first mammogram at age 40. And you can tell your family and loved ones and friends that that is the new standard. Age to stop mammogram is a little bit different. I'm just going to go to this next slide. So there really isn't an age necessarily that anybody says to stop. Some of them say 74, some of them say 75, but it really depends on the health of an individual person. So if somebody's very healthy and can actually tolerate cancer treatment, it's appropriate to continue to get mammography. And most of the societies say to get a mammogram every year. Some of them say every 1 to 2 years. The idea with this is that most breast cancer, because it can be very favorable, it, in a sense, the treatment and the survival will be the same whether you find it 1 year to the next. In terms of the cancer societies, they're pretty strong with getting it every single year. This is a copy of the NCCN guidelines, and the National Comprehensive Cancer Network creates guidelines that help guide cancer care so that people get high level quality standard of care. And this is just showing for the average woman who is over 40 to get an annual mammogram every year. They do recommend considering the 3D mammogram, also called tomosynthesis, breast awareness, and then consider supplemental screening for those with heterogeneous or extremely dense breast tissue. So I won't go into too much detail about this, but I just want to bring up some things that are kind of on the horizon for breast imaging. There's some very cool work being done actually with City of Hope collaborating with Cal Poly for photoacoustic technology of the breast, trying to understand if there's a way to see not only for screening, but also for sometimes when patients get an abnormal ultrasound or mammogram, if there's a way to tell if something's cancer without actually doing a tissue biopsy. Another thing which I definitely think will be in the future is a fast MRI. So current MRIs are long, they involve contrast. It can be a tough test for patients to have. you lie on your stomach during it, and you get the contrast. It's a very loud and long experience. And there have been trials where they've kind of done an abbreviated MRI to get some information, and that may be a win-win in terms of being able to do faster screening, less expensive, better comfort for a patient. And then the final thing, which has been being taken up nationally, is something called contrast enhanced mammography. This also involves a dye that would go in somebody's vein, but another way that may actually be comparable with MRI, but again, less invasive and less expensive, where you're given a dye and then they actually take mammogram pictures, and an area that looks suspicious for cancer will like light up in comparison to the surrounding breast tissue. So I'm very excited for us to improve breast imaging. The ability to early detect cancer is a big deal because the treatment matches the stage. So women that have early stage breast cancer potentially, don't need as extensive of treatment as somebody who's diagnosed as a later stage and needs, multimodality treatment. And that's really important. A lot of breast cancer survivors live in a sense with a lot of side effects from their cancer treatment. And yes, it was worth it, for a cure to be a survivor. But at the same time, we also have to pause and see what we can do to improve quality of life and prevent kind of this aggressive treatments to begin with. Genetic testing is something I'm very, very passionate about. So just like we talked about earlier in terms of like breast density and should I get an ultrasound, do I need an MRI? All women should have a risk assessment by age 25. What is their personal risk of developing breast cancer? This is especially true for Ashkenazi Jewish and Black women. There are certain genes in our body that protect us from getting cancer. So BRCA1 and BRCA2 are really commonly known. They are genes that actually help fix mistakes that can happen. So just like we're all human and we can make mistakes, our body also makes mistakes. We're renewing cells all the time. And when a mistake happens, our body has kind of mechanisms to deal with that. And BRCA is a DNA repair gene. And so when somebody has a BRCA mutation, they're born with one gene that is fully functioning and one copy that is not fully functioning. So in a sense, it is easier for them to get cancer because of, again, bad luck, things in our environment, exposures. If that other gene goes down, they develop a breast cancer. Ashkenazi Jewish women, there's 3 founder mutations in BRCA1 and 2 that they can be screened for. If anybody's ever had like 23andMe, this is like the mutations that they look for, but it's only 3. So really, if anybody wants a full genetic risk assessment, they should see a genetics doctor and have a full panel done. If somebody is gene negative, and I'll go over the genetic testing on the next screen, but let's just say they have a really high family history of breast cancer, or they have certain factors in their life that make them high risk. The risk calculators that physicians can do can take those into account. So things like family history, but no mutation, how old you were when you got your first period, when you went into menopause, if you used hormones, if you've ever had biopsies that show atypia, or other high-risk lesions. All of these factor into the risk for breast cancer. And the reason why these things are important is because the more menstrual cycles, the more periods we have in our life, actually the higher risk we are to get breast cancer. And that is because every time a menstrual cycle happens, there's a change in the body. It's preparing for a possible pregnancy. Anytime there's a change, there's an opportunity for a mistake. I use the analogy, like if you never drive, you'll never get in an accident. So if somebody is really young when they got their first period and never had any pregnancies and then went into menopause really late, they do have a little bit higher risk of getting breast cancer than somebody who was like 15 when they got their first period and they had 5 pregnancies and they breastfed for a long time and they kind of went into early menopause. So, I mean, nothing dramatic in terms of like a personal risk number, but as a population, we actually do see a difference in the risk factor history and the prevalence of breast cancer. The minority of breast cancers are genetic, but I still think it's really important to identify high-risk gene mutation carriers. These are the current guidelines from the National Comprehensive Cancer Network. So anybody who is diagnosed with breast cancer under 50, anybody who's had a type of breast cancer called triple negative, there used to be, these guidelines have gotten so much more broad throughout my training and career. But now anybody with a triple negative breast cancer, or anybody who's had breast cancer that has spread to other parts of their body, any male breast cancer. So there's a lot of different reasons why you may or may not meet criteria for genetic testing. But I really encourage everybody to talk to their doctors or even their primary care physicians and explore this. In the future, I do think there'll be genetic testing for all. They've talked about at age 40, just like a 4-gene panel testing for BRCA1 and 2, and then for 2 genes related to colon cancer. Colon cancer is another cancer that seems to be happening with increased incidence, likely potentially related to our diets. So I talk about breast cancer primarily, but I actually do ask a lot of my patients if they've ever had a screening colonoscopy. And if you haven't, this is your year to get it. It is a test that can diagnose colon cancer, but also see how high risk you are. If you have a lot of polyps, it can be therapeutic in that aspect too. We're very lucky at City of Hope. We have a very strong genetics department. A lot of the Southern California institutes are really strong in genetics, but we do have a precision medicine trial where any patient can get genetic testing. So I've seen patients, who had outside genetic testing that was kind of more limited, and we've done a bigger panel and found, kind of a life-changing gene mutation. The reason finding a gene mutation makes a big difference is if you know that you're high risk for a cancer, you can do high risk screening, or you can also do preventative surgery to prevent that cancer from developing. So an example of that is most of the gene mutations cause more than one type of cancer. So for BRCA1, it's breast and ovarian cancer. Ovarian cancer is actually a much more difficult cancer, not only to diagnose at an early stage, but also to treat once it's developed. So women with BRCA1 mutations, after they have completed childbearing, and then with the magic number of 35 to 40, are eligible to have their fallopian tubes and ovaries removed to prevent even developing ovarian cancer. So there's a lot of different gene mutations, and there's a lot of different cancers that patients can be high risk for. So everything is very individualized to the patient and their particular mutation and their family history. We'll transition now into prevention. So there's a lot of different things that can be done if we know somebody is high risk. And when we're talking about the most high risk patients, we're talking about a consideration of prophylactic surgery. Some patients that have high risk history in terms of atypias are also eligible to take medicine called chemoprevention. And it's medicine that we commonly use to actually treat breast cancer, but we also know can dramatically reduce the risk of getting breast cancer for somebody who's high risk. But the thing I want to talk to you about today is actually lifestyle management. So a healthy lifestyle can reduce your risk of getting breast cancer. So the top things are not using combined hormone replacement in longer than 5 years. Alcohol intake does increase the risk of breast cancer. The magic number being no more than 3 drinks per week. Exercise and also weight control. And these are all things that are good for your heart. So the most common cause of death is actually heart disease. And so everything that we're talking about for cancer risk reduction is actually very, very good for your heart. I believe environment matters. So we are exposed to so many things in terms of our diet, in terms of, plastics, in terms of things that we put on our skin. You can go down a deep, deep rabbit hole with looking at all the different ways that we may be exposing ourselves to carcinogens. And I don't think that anybody needs to, make drastic lifestyle changes, but I do think that our primary diet should be plant-based. We should not be eating red meat or processed meats on a daily basis. And I think there are some smart things that you can do in your everyday life to limit your exposure to chemicals and to plastic. So for example, using a laundry detergent that doesn't have fragrance, or choosing, I was just gonna say something, choosing like certain soaps and things like that. And again, this is a very nuanced discussion on their own, but I do feel passionate that this should be discussed with everybody who wants to do their part to reduce their risk of getting cancer. There has been studies, again, really looking at nutrition and breast cancer. And this was just sharing something from Europe. And so plant-based diet is one of the most important things. These are just two resources for beauty products that can increase risk. Parabens, I'm sure you guys see a lot, like the things on different plastics, like BPA free and things like that. That has actually really been scaled back in terms of products and things like that. But things like microwaving and plastics, that was the example I was going to use before. Like that's something easy that doesn't, that people don't have to do, but there may not just be an awareness about it. This is another, let's see, this is the app down here to look up things too. So now we'll transition to some new things that are happening in breast cancer research. The first topic is going to talk about de-escalation of surgery. So we actually don't want to over-treat patients with breast cancer. And then we'll talk about some trials that are coming up. So when women over 70 are diagnosed with breast cancer, sometimes they're very, very favorable tumors, and we can actually cause harm in our quest for a cure. So in 2016, the Society of Surgical Oncology released a guideline after review of the rate of nodal, like lymph nodes having cancer in them for women over 70, with again a very specific subgroup of tumors. So very small, estrogen-driven. They have to be appear to be node negative. And this is something we use commonly at City of Hope and other institutions, is to not routinely actually remove lymph nodes. This was confirmed this year. There was a great trial that was done across 18 European hospitals where they enrolled patients to actually have lymph node surgery versus no axillary surgery. And they used ultrasound, and if the ultrasound was normal, they concluded that patients can actually be spared axillary surgery because it doesn't actually change the treatment plan. So we are pending additional trial data. CEDARS has looked at this as well. And so I'm looking forward to more things that come out. But the main message I just wanted to share is that we're looking at ways to not surgically overtreat breast cancer while providing the exact same oncologic outcomes. The next trial is something one of my colleagues has open here at City of Hope, and it is called NovaLase. And this is a way to actually laser ablate breast cancer. So it's using a laser technology. So a minimally invasive approach to treat cancer without a surgery. So as part of this trial, patients still go on to get surgery at City of Hope for the protocol. But it is something that's very cool. There's been similar trials that have been done actually with freezing tumors called cryoablation. And so this is a great way to, again, kind of provide treatment for breast cancer, but not over treatment. Something I'm very, very excited about in the future, this is not mainstream in any way, shape, or form, is the liquid biopsy. So when somebody has cancer, there is a blood supply to that cancer, and there is a blood supply that goes away from the cancer. And there is shedding of DNA material from that cancer into the blood. And instead of doing a tissue biopsy, or maybe in addition to a tissue biopsy, A circulating tumor DNA would be actually taking a blood sample and looking for cancer material in the blood. And this is something that is not being studied uniquely to breast cancer. This is something that is being studied for all cancers. And it may allow us to diagnose cancer. It may also allow us to be able to personalize treatment to the DNA that is in the blood as a marker. You know, a lot of times when women get breast cancer, they want to know, obviously, if it's spread, a very normal instinct. And also, like, is my blood work normal? Is there any signs? And a lot of times blood work is normal. And, you know, there's not a blood test that's done that says, oh, yes, your cancer, you know, has spread or not spread. There's something called tumor markers, which can be elevated in the setting of breast cancer that's spread, but sometimes it can be normal. So I think this is something that's really going to change medicine. It is, again, not mainstream at this point. It's still being studied in a trial type setting, but I really, really look forward to it. This is just an example of a paper that was published this last year for patients that were actually undergoing chemotherapy for a type of breast cancer called triple negative. And they looked at the circulating tumor DNA cells basically before chemotherapy and during chemotherapy. And they could tell that the treatment was working because the circulating tumor DNA cell cleared. And they found that when they had surgery, then that was associated with a good response. So this is very, very exciting. And I really, again, look forward to this in the future. Another very exciting trial that we've had open at City of Hope and is open actually at multiple institutions across the nation is a multi-center robotic nipple-sparing mastectomy trial. All of breast surgery up until this point has basically been performed what would be called open, so making a cut and doing the surgery. And this is utilizing a Da Vinci single port robotic system to perform the mastectomy. Now, there is always a surgeon performing the surgery. So actually the first part of the surgery is done open for space for actually docking a lot of the robotic equipment. And then the surgeon goes over to the consult and we have a surgeon still scrubbed in with the patient. And so this trial is randomizing patients to have the surgery with robotic assistance versus open. It's very, very exciting. This is an example of where the surgeon sits, how the consult looks next to the patient. And then there's a screen for the people who are assisting to see what the surgeon on the console is seeing. The major goal of this trial is to prove safety of the procedure and also show similar oncologic outcomes in terms of margins. Very, very, very exciting trial. Again, that's open at City of Hope, but also other institutions across the nation and even in California. The next trial, which is almost going to be open at City of Hope, but again is also a national trial. And this is based out of a group from UCSF. There's an amazing organization that's run under a breast surgeon, Dr. Laura Esserman. And their goal is to further customize cancer treatment to patient biology. And this particular trial deals with pre-cancer. So when women develop breast cancer, it can be from the milk ducts or the milk glands. Milk duct cancer, when it is inside the ducts, is a pre-cancer called ductal carcinoma in situ. And this is the type of cancer that can be found on a mammogram because it has a tendency to make calcifications almost as like a byproduct trash. So we see these little breadcrumbs of these calcifications, and that can often lead to the diagnosis of precancer ductal carcinoma in situ. Precancer cannot spread to the body. It can turn into an invasive cancer, which can spread, but not all of them will turn into an invasive cancer. So the goal of this trial is to help further classify which precancer is the kind that will turn into invasive cancer, or maybe there's kind that doesn't need to have such aggressive, cancer treatment. For the trial, when somebody's diagnosed with DCIS, they undergo an adaptive randomization, and they are given medicine that can help prevent it from growing, an investigational agent. If there's changes over time, patients go on to have surgery instead of active surveillance. We were part of a very similar national trial called the COMET trial that also looked at non-invasive, basically observation for precancer as well. So this is very good. Again, in all of medicine and all of breast cancer treatment, there is just this balance where we don't want to overtreat patients, and more importantly, we don't want to undertreat patients. We want everybody to get, the best treatment, the least amount of side effects, the best cure, just a win-win everywhere. And all of these trials bring us one step closer to really being able to personalize more of the treatment to the patient's cancer biology. This is a very, very cool trial, and it does involve a lot of imaging. Some of these trials, it is, I admire patients that, are able to take the leap and be part of it, because it makes such a big difference. And so again, this is just looking if there's endocrine therapy that basically helps prevent progression of precancer. So I will just summarize everything one more time, and then I can help hopefully answer any questions anybody has. So mammograms should start at age 40. I believe every woman should have a risk assessment at age 25 and gene testing if indicated. There's a consideration for MRI and ultrasound if indicated. Healthy diet and exercise cannot be underestimated in terms of cancer prevention, but also protection of our heart. Avoiding the endocrine disrupting chemicals. And again, a rabbit hole to get into this, but I still think it's important to look at our environment and our lifestyles and do things that make a positive change in our cancer risk reduction. I'm looking forward to new imaging techniques. Hopefully that'll be less invasive, but allow for earlier detection of breast cancer. I think there's going to be more genetic testing in the future in terms of exciting things on the horizon. Less surgery, less invasive surgery, potentially just laser ablating tumors instead of cutting them out. The liquid biopsy, looking for circulating tumor DNA cells, robotic mastectomies, and non-operative management of precancer. So again, I'm delighted to speak with you all today. I'm so thankful to the cancer support community of Los Angeles, Abby and Kathy, for inviting me to give this talk. I work really closely with the San Gabriel Cancer Support Community. I refer almost every single patient to them because I think it's such a precious resource. Cancer treatment is the whole person, and they really fill a huge gap for my patients. So I'm very, very thankful.
Thank you, Dr. Schulz-Costello. We really appreciate your presentation, and we all learned a lot. And to our participants, please feel free to type in any questions into the Q&A chat. It looks like we already have a few, so we can go ahead and get started with those. So someone asked, what are your thoughts on diffusion-weighted MRI?
So diffusion-weighted MRI, the MRI, breast MRIs are done a little bit differently at different institutions. There's not a single protocol in terms of how they sequence giving the gadolinium dye and taking the pictures, but all MRIs include these like diffusion weighted images. MRIs without contrast are not useful for breast cancer screening. They are sometimes done actually to screen for silicone implant ruptures, which can be silent and not detected on ultrasound. But I'm not sure if that answers the question.
Yeah, I think that's great. Thank you so much. Someone else asked, can you provide a few more specific tips for prevention and lifestyle tips, maybe some nutrition tips you have as well?
Yeah, so I think honestly, most people should have at least one meal a day that is plant-based, so just eating fruits and vegetables. I fully acknowledge that I'm vegetarian, but I don't think you have to be vegetarian. But I think we can all look at like diets that we currently eat, menus at restaurants and things like that, and recognize that it's actually more of a challenge to eat plant-based. I do think Los Angeles as an area is more friendly in promoting some healthy food things, but I think just adding fruits and vegetables to meals is the most important thing.
Great, thank you. And someone asked, is the risk assessment typically covered by insurance as part of preventative care?
That's a great question. So risk assessment is just like something a primary care, a GYN, or like a breast surgeon can do. It's honestly just part of like a visit. I don't think it's anything that is like I use two online calculators for most patients. One is called the Modified Gale Score. It takes into account your personal history of like your first period, if you've had breast biopsies, what they've shown, any first degree relatives. You can do this on yourself. It'll give a score of your lifetime risk of breast cancer and your risk of developing breast cancer in the last 5 years. These tools are not used for women that have already had breast cancer or genetic mutation carriers. And the other score that I use is called Tyrer-Cuzick, and that one I use a version that actually incorporates breast density. Having denser breasts is a little bit increased risk for getting breast cancer, not only because mammograms aren't as sensitive, but likely it is a reflection of breast changes from hormones. So that scoring system I use also incorporates the breast density. It usually gives a higher score, and then I'll use kind of like the middle number.
Perfect, thank you.
Hmm.
And then someone asked, why is menopause a risk for cancer?
It's a great question. It's a change. It's a loss of hormones. So again, anytime there's like a change in the body, higher risk. Yeah.
Thank you. And then what are your thoughts on sure touch tactile imaging?
Shared touch tactile imaging.
Yes.
I am not familiar with that. So I will look that up.
Um, and then someone asked, what are your thoughts on cancer vaccines, like the one like Anixa has in phase 1 trials?
I am not familiar enough with those to eloquently or educatedly answer that question.
Perfect. Thank you.
Hmm.
Um, and then how do we know what beauty and household products are safe?
So the EWG is probably the easiest website to like navigate. Some of the other resources that I listed, you can look them up, but for household EWG.
Thank you.
Hmm.
Um, and then someone has stage 4 cancer. They're asking if DNA-driven tests help women.
Is that looking at circulating tumor DNA in the blood? If that is what you were referencing, honestly, it's a very individual decision. Some patients have other markers, like the tumor markers that can be followed. When breast cancer is metastatic, so it's spread to other parts of the body, and you are receiving treatment, you want to know if it's working or if it's not working. And so the ways that are traditionally done to do that is by imaging, which again can be invasive, anxiety, time, everything. Or sometimes by blood work, which are tumor markers. So there's two tumor markers that can be elevated when breast cancer has spread. However, sometimes they're also normal. When they are elevated, the medical oncologist can use that as like a surrogate for how somebody is responding to treatment. In other words, they like start a medicine and they retest the blood and see that the tumor markers are going down. So circulating tumor DNA is being studied right now for metastatic cancer in that sense for certain types of cancer, especially triple negative breast cancer, but it is part of a trial at this point.
Perfect. Thank you.
Mm-hmm.
And someone wants to know if there are any trials using ctDNA like Signatera to possibly de-escalate adjuvant treatment.
I don't know of any right now, but I know there will be because that would be like a goal. Like, what if somebody? It's a like, what if somebody doesn't need to have systemic chemotherapy because they have no circulating tumor DNA cells? Yeah, there could be something open right now. I'm not aware.
Great, thank you.
Yeah.
And someone wants to know if there are any websites you can suggest for healthy lifestyles, for food, makeup, or chemicals, that one should stay away from.
Yeah, I'll go back to my slide about the different websites. I think this field will like continue to expand. There's like nutrition oncology that's becoming more common. Like in an ideal world, I think every patient should almost have like a lifestyle doctor, a lifestyle guide. And that would include both nutrition as well as a field called exercise oncology. There's some really interesting papers that have been published where they have shown when you exercise how it increases your immune system's ability to fight cancer. So these three things together, I think, can make a big difference in someone's life. Another one that I use is called Give Me the Good Stuff. It's a mom from Brooklyn, and she reviews some products too. Um, and I'm excited that people are asking questions about it because I think it's sometimes an overlooked area in our life in terms of risk reduction.
Yeah, thank you. Um, and then someone asked, can you talk about HRT versus non-HRT?
Yes. Okay, so hormone replacement therapy is sometimes villainized when women go through menopause. And this is kind of unrelated to cancer patients. So a lot of time when women get cancer treatment, they are unfortunately placed in a menopausal state because the most common breast cancer is estrogen and progesterone driven. So a lot of our adjuvant treatment for breast cancer involves sometimes people go into menopause because they got chemotherapy. Sometimes women are in menopause because they're getting a medicine that is putting their ovaries to sleep. And sometimes people go into menopause surgically because they have their ovaries removed. So as a separate topic from cancer related is hormone replacement therapy. And so when women go through menopause, they no longer have the same levels of estrogen and progesterone in their body. And hormone replacement therapy increases the risk of getting cancer. And primarily, it's actually the combination of estrogen and progesterone for longer than 5 years. So there's not like it's not a black and white issue in terms of like, oh, is it safe? I don't think someone should be on hormone therapy forever. I also don't think that women should be discouraged from hormone replacement therapy. I think it should just be acknowledged and it should be done in the safe way. The safest form of hormone therapy is actually estrogen-based therapy. However, if you have not had a hysterectomy, you cannot take estrogen by itself because unopposed estrogen alone, can increase your risk of getting like uterine cancer. So the progesterone helps prevent increased growth of the lining of the uterus. So just like everything, there's like a yin and yang, and you can chase, try to correct something and then you cause a problem with something else. But it's great to see a doctor who commonly helps menopausal women with hormone replacement.
Great, thank you. And someone is asking if you know of any trials that you would recommend for someone with triple negative. They're stage 4.
So I do think we have a circulating tumor DNA trial at City of Hope specifically for that. And I would actually suggest going to clinicaltrials.gov if you haven't been on that website. City of Hope also has a subgroup website through our thing if you want to look up anything. But if you do clinicaltrials.gov and you're in the LA area, I feel like you'll be able to have more access to more trials. We're very blessed in Southern California with a lot of like great institutions who are doing a lot of great research.
Great, thank you.
Yeah.
Um, and then what are your thoughts on fasting for prevention or for prevention of cancer or during chemo?
Fasting.
Yeah,
Um, I don't think that it is helpful. I've been following a nutrition oncologist kind of education, and there is an idea that cancer feeds on sugar. So if we fast or we don't have a lot of sugar, that we're not like feeding the cancer, but in a sense, like our body runs on sugar. So no matter what you eat, it's changed into the, like the fuel for our body. So I don't think, again, anybody needs to do like a keto diet or a no sugar diet. Intermittent fasting, there was some data that showed some patients tolerated chemotherapy better with it, and I don't know if it was necessarily related to the fasting versus like just like the side effects of chemotherapy. But yeah, in general, I don't think that it's something that's like a game changer.
Great, thank you. And someone is asking if it is okay to have soy products if you have breast cancer.
Yes, that's a great question. So soy actually contains phytoestrogens. And having that word estrogen in the name is scary because it's like, gosh, what if you're like promoting cancer. But phytoestrogens are actually very safe in Asian countries where they have a high intake of soy products. We actually see a decreased incidence of breast cancer. So it's like soy is safe. What I don't recommend is like high volume soy. So like if somebody was eating, I don't know, like a protein bar with soy like 3 times a day, but things like soybeans and tofu and stuff are absolutely safe. I eat that as well.
Great, thank you. Um,
Hmm.
and someone asked, does progesterone increase risk of breast cancers?
Yes, in a sense. Yes. Over time, yes.
And someone is asking, do you know any information about letrozole, Zamato infusions, and Kisqali? Sorry.
Zometa and Kisqali, yes. So again, as a surgeon, my I don't know if you're looking for something particular about those medicines. Zometa is a medicine that helps your bone, so it's treatment for osteoporosis, but it's also useful as an adjuvant treatment for breast cancer in terms of decreasing the risk of cancer going to the bones. And this is my understanding of it is that medicine is stimulating your bones to make more bone, okay? And as the bone is like in a sense creating more bone, it's harder actually for cancer to set up in the bones, to grow in the bones. So they've seen that when patients who are higher risk to get bone cancer, so spread of breast cancer to the bones, that being on a medicine like Zometa is actually helpful in reduction of risk of bone spread. And unfortunately, again, the yin and yang of it, like women that go through menopause or have the side effects of not having hormones are higher risk for osteoporosis. So then the Zometa helps in that way. Kisqali is a CDK4/6 inhibitors. These were a bit of a game changer for women with estrogen-driven breast cancers, primarily because these cancers feed on estrogen. Most of the treatment involved anti-estrogen pills, so a medicine like tamoxifen, or an aromatase inhibitor, which actually prevents estrogen in the body from being created by blocking an enzyme in the blood. CDK4/6 inhibitors were first studied in metastatic breast cancer, but now they're used as an adjuvant therapy for higher risk estrogen breast cancers, and it reduces the risk of cancer coming back and also the risk of recurrence in the body.
Perfect. Thank
They sometimes are tough to tolerate, but I trust you're in good hands with wherever you're getting therapy in LA.
you.
Hmm.
And then someone asked if there is a greater risk for getting breast cancer if someone has been taking birth control for 5+ years and is under the age of 30.
Can you say it one more time?
Yeah, so they're asking if there's an increase for early breast cancer or later on in life if someone has been taking birth control pills for 5+ years and is under the age of 30.
A very small risk, but nothing that I would say like there's no reason to change anything.
Great. Thank you. Um, And then just one last question. Someone is just asking if you consider yourself a holistic and or integrative doctor.
And do not have the title of an integrative doctor. We do have an integrative medicine program at City of Hope that's led by Richard Lee. My title would be breast surgeon.
Great. Thank you.
Yeah.
And actually just one last thing. Someone is asking if they can reach out to you to ask additional questions. You would be interested in sharing.
Yeah, I think is Crystal here in the chat? She can send out some contact information. I'm gonna try to get out of the screen and see. Oh no. Oh no, I'm still on, right?
Yes, you're still screen sharing.
Okay, hang on. Let's see if I can see it. We'll see if we can get contact information set out.
Yeah, we can, no
yeah.
worries. We can also follow up with our
Yeah.
participants later. But thank you so much for all of your information and for taking the time to share with our community today. We truly appreciate you sharing all of your knowledge, and I know we all learned a lot. And then Kathy, I believe we have one last closing slide before the end of the webinar. So if you all would like to learn more about Cancer Support Community Los Angeles, please feel free to visit us at cancersupportla.org. We also have two breast cancer groups. Right now we have a breast cancer support group that meets on Mondays from 6 to 8 p.m. And then we also have two metastatic breast cancer groups that one meets on Tuesdays from 5 to 7 p.m. and the other meets on Thursdays from 3 to 5 p.m. If you would like to learn more information about how to get started with this, or if you have any other questions, please feel free to email us at info@cancersupportla.org. Other than that, thank you so much, Dr. Schulz-Costello, for being here with us today. And thank you to our participants for engaging with us. We truly appreciate all of your time, and we hope to see you all at the next one. Thank you. Bye.
Thank you guys so much.